Hey everyone, today we'll discuss some questions on localizing the strokes. My name is Dr. Susan Kafle. Now that we're done with most of the concepts that are required to solve such questions, let's begin. Question number 1. A 65-year-old woman is brought to the emergency department 2 hours after sudden onset weakness in her left arm and double vision. Her medical history is significant for hypertension and atrial fibrillation. On examination, her blood pressure is 150 by 90 millimeters of mercury and pulse is 88 per minute. She is alert and oriented with normal speech. The right eye shows drooping of the eyelid. The pupil is enlarged and the eye is deviated outwards. The left eye and its movements are normal. Muscle strength is 4 by 5 in the left upper and lower limbs and normal on the right. Deep tendon reflexes are brisk on the left and normal on the right. Babinski sign is present on the left. Sensation and coordination are intact. Which of the following is the most likely location of the patient's lesion? So whenever you are trying to solve the questions on localizing the strokes, first try to find out if there are crossed signs or ipsilateral signs. By crossed signs I mean there would be involvement of one side of the face and the other side of the body. In this question, the right eye shows drooping of the eyelid, pupil is enlarged on the right side and the eye is deviated outwards. This signifies that there is involvement of the right oculomotor or the third cranial nerve. Alright, but the weakness is present in her left arm, so there is involvement of the left side of the body. So this is a crossed sign. When we have crossed sign, we always think of stroke in the brainstem. Now if we try to localize the symptom where in the brainstem the stroke is present, since we have the involvement of the third cranial nerve, the answer would directly be midbrain. But let me explain this to you. We have already discussed this in our previous videos, but if this is the brainstem, this is an arbitrary line that is drawn from the midline, and these horizontal lines divide the brainstem into three regions: midbrain, pons, and medulla. In midbrain we have cranial nerve nuclei number 3 and 4, in pons 5, 6, 7, 8, in the medulla 9, 10, and 12. So in the midbrain we have cranial nerve nuclei number 3 and 4 towards the medial side. So the answer would be midbrain to this question. By the way, so there are different types of midbrain syndromes. Do you guys know which syndrome is present in this patient? There are basically 5 different types of syndrome. One is the Weber's, the other is the Benedict, third one would be Claude, fourth is North-Nagel, and fifth one is the Parinode. We have discussed this in our previous video on midbrain syndromes. In this patient we have the involvement of the third cranial nerve nuclei as well as the corticospinal tract. So these two structures are involved only in either the Weber syndrome or the Benedict syndrome. But in Benedict syndrome we also have the involvement of the red nucleus and substantia nigra, which is not seen in this patient. So the likely diagnosis in this patient is the Weber syndrome. Right? Question number 2. A 72-year-old woman is brought to the emergency department by her daughter 1.5 hours after she suddenly became dizzy and fell while walking. According to her daughter, the patient experienced several episodes of vomiting and blurred vision immediately before the fall. Her medical history is significant for type 2 diabetes, hypertension, and atrial fibrillation. Current medications include metformin, lisinopril, and warfarin. BMI is 26. On examination, she is alert and oriented. Vital signs look normal except the pulse and the blood pressure, which are slightly high. Neurologic examination reveals right-sided facial droop, dysarthria, difficulty swallowing liquids. Muscle strength is 4 by 5 in the left upper and lower limbs. Right-sided strength is normal. She is mildly ataxic when walking. These findings are most consistent with infarction in the territory supplied by which of the following arteries? So again, let's try and see if this patient has crossed signs. We can see over here that there is right-sided facial droop, but left upper and lower limb weakness. So this is a crossed sign, which means that the stroke is present somewhere in the brain stem. So where in the brain stem is the stroke present? Since the facial nerve nuclei is involved, we should directly be thinking of involvement of the pons. But you might say that there is also dysarthria and difficulty swallowing, which would occur due to involvement of the 10th cranial nerve, which is present in the medulla but not pons. But we know that the upper motor neurons of the motor cranial nerves descend in the upper pons via the corticobulbar tract. So we have the lesion in the medial pons over here. In the medial pons, since there is right-sided facial droop, so the lesion would be on basically the right side here, somewhere around here. So there are two descending tracts lying in the medial side of the pons. One would be the corticobulbar tract, the other is the corticospinal tract, and there would also be the involvement of cranial nerve nuclei number 6 in the medial pontine syndrome. Can we see any finding of the cranial nerve 6 involvement in this case? I don't think that we have it mentioned over here, but they often, like, don't mention all the different signs, but you have to figure out with the given available signs that are given in the question. So, but you might also say that why is this not lateral pontine syndrome rather than the medial pontine syndrome? Because the 7th cranial nerve is involved in this case. So 7th cranial nerve is present on the lateral side, so why are you saying the medial pontine syndrome? So you are right to say that, but we know that the corticospinal tract is not present on the lateral side. It is present on the medial side of the pons. And we also know, if you have watched my previous video, we know that there are three variants of the medial pontine syndrome that would present with some extra manifestations than the classic presentation. There was a mnemonic, Ray's Mill Factory, Ray's for Raymond syndrome, Mill for Millard-Gubler syndrome, and then Factory for Faubil syndrome. In Millard-Gubler and Faubil syndrome, apart from the involvement of the cranial nerve nuclei number 6 and corticospinal tract, we also have involvement of cranial nerve nuclei number 7 because the lesion extends somewhat towards the facial nerve nuclei. So in this patient probably has Millard-Gubler or Faubil syndrome, which are variants of the medial pontine syndrome. So the answer to this question would be vertebro-basilar artery, because the basilar artery, the paramedian branches, are supplying the medial pons and are involved in the medial pontine syndrome. All right. Question number 3. A 28-year-old man is brought to the emergency department after a bicycle accident. He complains of sudden onset neck pain and headache but denies double vision, weakness and numbness. Initial imaging reveals a fracture of the right C1 vertebra with no other abnormalities. He is placed in a cervical collar for stabilization. Several hours later, he develops vertigo, hoarseness, and numbness on the right side of his face. On examination, there is right-sided ptosis and constricted pupil, horizontal nystagmus, reduced pain and temperature sensation on the right side of the face and left side of the body. Ipsilateral limb ataxia and dysmetria is also present. Hearing is normal. So which of the following artery is involved in this patient? So the options basically have the arteries of the circle of Willis. So let's draw the circle of Willis real quick. These are the vertebral arteries combined together to form the basilar artery. In the middle we have anterospinal artery. Here is the PCA, then the posterior communicating artery, then the internal carotid artery is giving off MCA, and ACA that runs towards the top, right? So what syndrome does this patient have? Are there cross signs in this patient? Yes, because the pain and temperature sensation are gone on the right side of the face and left side of the body. So this lesion should be somewhere around the brainstem. The brainstem is divided into three parts: the midbrain, pons, and the medulla. Now we don't see any signs of oculomotor nerve or trochlear nerve involvement, so this lesion is not here. This can be in the pons or the medulla. Now we see whether it is present in the lateral pons or the medial pons. There are some signs to suggest this. The patient has right-sided ptosis and constricted pupil, which means there is right-sided Horner syndrome. Horner syndrome would result from the involvement of the sympathetic fibers which are present on the lateral side of the pons and the medulla. All right. The patient has a reduced pain and temperature sensation on the right side of the face. So there would be the involvement of the fifth cranial nerve, which extends the nuclei of which extend into the medulla as well. We have them in the pons as well. So there is ataxia and dysmetria, which would result from the involvement of the cerebellar peduncles, the middle or the inferior cerebellar peduncles, which again could mean pons or medulla as well. But the hearing is normal. So if hearing is normal, in pontine syndromes we have involvement of the, in lateral pontine syndromes we have involvement of the labyrinthine artery or the eighth cochlear nerve nuclei. So basically this means this normal hearing means that the lesion is not in the pons but in the medulla. So we basically are having the lateral medullary syndrome on the right side. So lateral medullary syndrome would occur because of this involvement of this artery from the vertebral artery, this branch that is called pica, posterior inferior cerebellar artery. We don't have posterior inferior cerebellar artery in the options, so the closest option would be the vertebral artery because it is a branch of the vertebral artery. So the correct answer is F. Question number 4. A 68-year-old woman is brought to the clinic because of sudden onset of uncontrollable movements of her left leg and arm. Earlier today, while attempting to drink tea, her arm threw the cup out of her hand. She has a history of poorly controlled hypertension and hyperlipidemia. She does not drink alcohol or use recreational drugs. On examination, there are irregular, violent, flinging movements involving the proximal muscles of the left upper and lower extremities. Which of the following brain structures is most likely damaged in this patient? So this thing, the irregular, violent, flinging movements, gives away the answer to this question. This would be hemibellismus. So we have already discussed in our previous videos that hemibellismus is due to the involvement of the subthalamic nuclei, which would be involved in case of the proximal PCA stroke from the P1 segment, this segment. All right, so the answer to this question would be subthalamic nucleus. Question number 5. A 70-year-old man comes to the emergency department after suddenly developing dizziness and hoarseness while eating lunch. His past history is notable for long-standing type 2 diabetes mellitus. On examination, he is alert and oriented. Neurologic testing reveals impaired pain and temperature sensation over the right side of his face and left side of the body. The uvula deviates to the right and the gag reflex is absent on that side. Motor strength is preserved in all extremities. The vascular lesion is most likely located in which of the following areas? Again, here we see that the pain and temperature sensation are impaired on the right side of the face and the left side of the body. This implies crossed signs again. Crossed signs means there should be stroke in the brainstem. Since we have now the hoarseness of voice, cranial, so let's do CTP again. Cranial nerves that are involved would be cranial nerve number, dizziness suggests 8V, hoarseness suggests 10, and then pain and temperature sensation is lost on the face, right side of the face, so that would mean 5. The tracts, if we look at the we also have the uvular deviation to the right, so that would be cranial nerve number 10. And then so even the gag reflex is absent, which means cranial nerve number 10 is involved. And then there is no motor involvement. Which of the following, which tract is involved in this case? Pain and temperature sensation is lost over the left side of the body, so there would be involvement of the right spinothalamic tract on the on the brainstem, or in the brainstem. So the lesion would be on this midbrain, pons medulla. The lesion would be somewhere around this side in the right lateral medulla. So the answer to this question would again be right lateral medulla. This is the medullary syndrome. All right. Question number 6. A 66-year-old man with a history of uncontrolled high blood pressure is brought to the hospital after suddenly collapsing at home. His wife reports he developed weakness on the left side of the body and difficulty speaking. On arrival, his blood pressure is 220 by 110 millimeters of mercury. Neurological examination reveals left-sided hemiplegia affecting the face, arm, and leg, along with impaired sensation and slurred speech. The patient is drowsy but arousable. Head CT without contrast shows hemorrhage on the right side as shown aside. Which of the following arteries is most likely the source of bleeding in this patient? So we can see that there is a bleeding over here with some intraventricular extension. So if we look at the CT scan itself, this is the area of the internal capsule. This one, we have the caudate nucleus over here, and the other putamen, globus pallidus, internus and externus in this area. We have thalamus towards this side. So this central area is the internal capsule area. So this is an internal capsule stroke. But if we try to derive this from this history, so in the stroke of the internal capsule, we basically have 4 types of syndromes. One is the pure motor, other is the pure sensory, which is rare. The third one would be sensory motor, and the fourth is the dysarthria, clumsy hand syndrome. So we have impaired sensation as well as hemiplegia. So this is a type of sensory motor stroke that is due to the involvement of the internal capsule, specifically the posterior limb of the internal capsule. So there are no cortical signs. By cortical signs I mean aphasia or neglect or prosopagnosia or visual field defects. There are nothing mentioned in the question. So this would be a stroke of the internal capsule which is due to the involvement of the lenticulostriate arteries. Question number 7. A 54-year-old man is brought to the emergency department because of sudden difficulty speaking. He is alert and follows command but speaks in short, broken phrases such as "go home later." He becomes visibly frustrated when trying to express himself. His wife reports that he can understand what she says and can point to objects correctly but struggles to form sentences. Neurological examination shows mild weakness of the right lower face and the right arm. Which of the following is the most likely damaged in this patient? So now we have the signs in the face and arm on the same side, so we should be thinking higher than the level of the brainstem. All right, I think this is clear to you. So when we are thinking above the brainstem, so we have internal capsule, we have the cortex. So these are the main 2 areas where the strokes can be present, and which are mostly tested in the questions. So what cortical sign is present in this case? The patient is not being able to express himself, so this is expressive aphasia. Is trying to find words to speak, like is speaking in one words and not forming sentences. So this is Broca's aphasia, and Broca's aphasia would be present in MCS stroke. The patient also manifests some other features of MCS stroke, which is the weakness of the lower face and the right arm. So Broca's aphasia is due to the involvement of the dominant hemisphere, where the Broca's area is present, specifically on the this side, which is the frontal lobe. Sorry, I'll erase this. So the Broca's area is present on the frontal lobe in the inferior region, which we call the inferior frontal gyrus. So the answer would be the left inferior frontal gyrus. Left because the Broca's area is present in the left side of the brain in right-handed people. Most of the times it is present in the left side. Let's do the last question and wrap this up. A 67-year-old right-handed man is brought to the hospital because of sudden weakness. His wife noticed that earlier in the day he had trouble lifting his left arm and that the left side of his face looked droopy. On arrival, he is alert, but his eyes deviate towards the right side. Neurologic examination shows weakness of the left face, arm, and leg. When asked to copy a picture of the house, he draws only the right half and ignores the left side. Injury to which of the following arteries is the most likely explanation of the patient's finding? So, as you can see over here, there is weakness in the left arm and left side of the face, which means the lesion does not show crossed signs, and so it is above the level of the brainstem. Now if we try to look at the cortical signs and see if they are present, we can find two cortical signs here. The eyes are deviating towards the right side, which implies the involvement of the frontal eye field areas, and then uh, we also have neglect. All right, so neglect would be present when the lesion is in the non-dominant hemisphere, that is the right side. If there is involvement of the dominant hemisphere, we'll have aphasia. In non-dominant hemisphere, we'll have construction apraxia, anosognosia, and neglect. So the right MCA territory is involved in this patient, and the answer to this question would be C, because this is the internal carotid artery and C is the middle carotid artery. This one here is the ACA, so the answer is C. Alright guys, so that would be it for this video. I know it is a very difficult concept to take in all at the moment, so I suggest that you guys watch my videos on different syndromes like the Pontine syndrome, medullary syndrome, midbrain syndrome, and ACA-PCA and MCA strokes. This is a very high yield topic for any exam. Like, you are very sure to get the questions from localizing the strokes in your exams, so I suggest that you get all the concepts properly before you take your exams. So thank you. See you in my next video. Bye. Have a great day.